Hello friends, welcome to Health, Music and Fitness channel. In the previous videos we discussed about electrocardiography. We discussed the basics of ECG and we discussed about what ECG paper is, what the calibration is, and what are the different waves. The P wave is there, QRS, and the T wave is there. We also discussed about the different durations of the different waves and the intervals, the QT interval, the PR interval, and we also discussed a little bit about the shapes of the different complexes, the P wave, the QRS, and the T wave. In today's video, we'll be discussing about a very important topic in ECG, that is the axis. Everything in ECG is about axis, and the diagnosis changes, everything changes when the axis changes, and it is very important in almost every arrhythmia, in almost every disease condition. The axis will be affected some way or the other. Whatever disease, whichever disease which affects the heart will affect the axis. Let's say for example lung diseases. In bad COPDs causing cor pulmonale, you will see a right axis deviation. In pulmonary embolism, you will see right axis deviation. To the extent, and if a patient with COPD, you have a patient with COPD, he is coming to you regularly in the OPD, and his ECG shows, his ECGs, previous ECGs, they show right axis deviation, and suddenly he comes to you with breathing difficulty, which has suddenly worsened, drop T is negative, and you do the ECG, and there is a shift in the axis. There is a more further rightward shift of the axis. In that case, you should think about pulmonary embolism. That is one of the things we should always remember. In a person with right axis deviation, if there is a further deviation of the right axis and the drop T is negative, you should think of pulmonary embolism, because there is a sudden strain on the right ventricle as there is a pulmonary embolus lying there. Camera on. Welcome back. I had to take a short break because my dogs were getting restless and Roman is hiding under the chairs and he is crying like a baby. Anyway, coming back to the axis. If you have lateral wall MI, it will cause a shift of the axis towards the right side. Similarly, in inferior wall MI, you will see a shift of the axis towards the left side. The patient will suddenly develop a left axis deviation. Bundle branch blocks. Left bundle branch block, it will cause left axis deviation. Right bundle branch block, it will cause right axis deviation. And left anterior hemi block, again it will cause LAD, left axis deviation. And left posterior fascicular block, it will cause right axis deviation. We'll also discuss in detail how to differentiate between these conditions which cause the axis shift. Even left ventricular hypertrophy can cause left axis deviation. There are many other conditions which can shift the axis. We'll discuss all those in detail, but first we have to know how to determine the axis. There are different leads. There are augmented limb leads, AVR, AVL, AVF. Then there are standard limb leads, lead 1, lead 2, lead 3. And there are anterior chest leads, V1 to V6. In a normal traditional ECG, we take lead 1, lead 2, lead 3, AVR, AVL, AVF in this sequence. Then after that, V1 to V6. And most of the modern machines, they will also record a long lead 2 separately or in the same rhythm strip, so that we can interpret various blocks and various arrhythmias, because in a standard normal ECG you will see only 2 or 3 ECG complexes in each rhythm, in each lead. Lead 1 will show 3 complexes, lead 2, 3, and so on. So it is very difficult to comment on complicated blocks, complete heart blocks, type 2 AV blocks. It is difficult to comment on them in short, in 2 or 3 complexes. You have to read through a long strip. So long lead 2 is always recommended whenever you want to comment on the blocks or some complex arrhythmia. Then you have to draw a circle. I call it circle of life. Like in this chart, you can see a circle, and in this circle we will draw two 90-degree lines, and like this is 0 degree, that is 180 degree, then that is minus 90 and plus 90. Above the line which is passing through the center of the circle horizontally, this is the negative component and this is the positive component. Then at 0 degree axis we will plot lead 1, that is the positive pole of lead 1. Then at minus 180 we will plot the negative pole of lead 1. Similarly, AVF at plus 90 is the positive pole of the AVF lead, and at minus 90 is the negative pole of the AVF lead. Then you have to remember all these leads placed in this circle, they are lying at a multiple of 30 degrees. So it could be 0 degree, 30 degrees, 60 degrees, 90 degrees, 120 degree, 180 degree, minus 30, minus 120, like that. And I told you lead 1 positive pole is at 0 degree, negative pole is at 180 degree. Similarly, lead AVL is at minus 30. Mind it is minus 30 degrees, but that is the positive pole of lead AVL, and the negative pole of AVL will be, it will be a straight line. So the negative pole of AVL will be welcome back. So similarly, lead 1 is at minus 30 degrees, that is the positive pole of lead 1, and the negative pole will be at plus 150 degrees. Similarly, lead 2 is at plus 60 degree, and the negative pole will be at 120 degree, minus 120 degree. Then AVR is at minus 150 degrees. So like that you have to plot the different leads, and lead 3, the positive pole is at 120 degree, the negative pole is at minus 60 degree. So like that you have to plot the different leads. We were discussing the circle in which we have plotted the different leads, like out here. Whenever you are given an ECG, always look at lead 1. You have to go systematically. They say you have to interpret at least 100 ECGs using this circle in your mind, and you have to train your mind in such a way that while you are scrolling through the ECG paper, your subconscious mind automatically maps the findings on that circle in your brain, and then it is just maths. It's a habit, and for first 100 ECGs if you do, then it will be a habit. Then your brain will automatically convert whatever you are reading, and it will translate into that circle which I have shown you out here. I promise if you do this, you will become a master in the ECG. Never bypass these 3 steps: rate, rhythm, axis. Always rate, rhythm, axis. And then you look at the intervals, you look at the complexes, the shape, the duration, and you will miss nothing in ECG. Now you should always remember, current can travel only in one direction. Current cannot travel like this. It cannot travel to the left and the right. It will travel either from left to right or right to left. And in the ECG case, on the various electrodes, these are the positive pole of the electrodes which I have drawn out here. Okay, and the current will travel towards the positive pole of these complexes, and whenever the current is traveling going towards the positive pole of any of the lead, it will be perceived as a positive deflection, an upright deflection. And whenever the current is going away from the lead, it is perceived as a negative deflection. It will form a Q wave or the S wave. They put an electrode into the center of the cavity of the left ventricle, and all the leads, they recorded a Q wave, because in that case the current is not going towards the electrode, because current in the ventricles, it travels from within to outwards. It travels from the endocardium through the myocardium to the epicardium. So it is like that. It doesn't come inwards into the cavity. So if you place an electrode in the center of the LV cavity, it will record a Q wave, because the current is going away from it so far that electrode in the center of the LV cavity is concerned, because it is not that the current is going through the electrode into the myocardium, it is just recording. The SA is firing, it is going to the AV, it is going to the His bundle, it is going into the right and left bundle branch block, right and left bundle branches, and it is further going into the myocardium on the left side, from left anterior fascicle and the left posterior fascicle. And sometimes in some of the books it has also been reported that there is a septal fascicle also on the left side. Most of the books say there are the left bundle branch divides into left anterior fascicle and left posterior fascicle, but some books say there is a small septal fascicle also which supplies the interventricular septum. And you have to remember, the interventricular septum, it is the first part of the myocardium that depolarizes, and the depolarization starts from the left to the right side. Okay, it's very important, because the electrodes that are facing towards the interventricular septum, they will perceive the current as going towards them, and they will perceive it as a R wave. But also remember, interventricular septum is not very bulky, it is a thin muscle layer, and so it records a very small R wave, very small R wave. And the reciprocal of that deflection, when the current is going from left to right to depolarize the left interventricular septum, in lead V5 and V6, it is perceived as if the current is going away, like out here. V1 is out here, V2 is out here, and for V1 and V2, the current is going towards them. So V1, V2, they will record a small R wave from the IVS. But at the same time, in V5, V6, AVL, lead 1, what is happening? You will see a normal looking small Q wave. Now mind you, that Q wave is not because of myocardial infarction. In lateral leads, you will see a Q wave, and that is because of interventricular septum depolarization. It is not because of MI, it is because of the depolarization of the interventricular septum. So just to recapitulate, small R in V1, V2, small Q in V5, V6 is the same current from left to right which is depolarizing the interventricular septum, and that is how we get a small R in V1, V2, a small Q in V5, V6, lead 1, AVL, and these Q waves are normal waves. These are the waves which represent depolarization of the interventricular septum. At this point, you should also make a mental note that T follows R. If the R wave is small, T wave will be small. If the R wave is tall, T has to be tall, T should be tall. And if the R is tall, T is small, it could mean patient has a coronary artery disease, there is ischemia. If R is tall, T is flat, ischemia again, and many other things which can cause flattening of the T wave. R is tall, T is inverted, like in LVH with strain pattern. There is a defect in the repolarization. So then the T inverts. Some electrolyte changes invert the T wave, and some drugs like digoxin, it will invert the T wave. You will get the digitalis effect or a sign of digitalis toxicity. You must have noted right from the start of this series, I have been talking a lot on digoxin because it is one of the best drugs, very safe drugs, but these days people use it very less. And in the past, people used to use digoxin and they got fantastic results. And you can do a lot of things with digoxin. Coming back to the axis. So T follows R. You have to always remember. If R is small, T will be small. T should be small. If R is small, T is tall. You should think of hyperkalemia. And if R is small and T is flat or inverted, like in lead V1, it is normal. You should never comment on T wave in lead V1 because T wave can be inverted in V1 in small children and female pattern ECG. You will see T wave inversion up to V1, V2, up to V3. So if R is small, T can be flat, there can be a small T, there can be an inverted T, like in every normal looking ECG. Like in this ECG, you see there is a small r, T is flat. Small, next slide, yeah, small r and inverted T in V1. But if the same thing we see in lead V5 and lead V6, which are looking over the left ventricle, which is a very bulky muscle. Left ventricle is a very bulky muscle. It has to, so it will produce a lot of electricity, and all these electrical impulses will be perceived by the laterally oriented leads, V5, lead V6 and lead 1 and AVL. So they will perceive a lot of current coming towards them. So these laterally oriented leftward leads, they should record a very good amplitude R wave, and if the current is not going further away, then they will not record a S wave. S wave, what is S wave? S wave is when the current is going away from the positive pole of any of the lead. Now in this diagram, you see in this diagram, that is why it is important to at least interpret at least 100 ECGs. I would say 1000 ECGs. When I was doing my MD, as MD's residents in Christian Medical College, Ludhiana, we used to be handed over a big pile of ECGs when we were on call on our post-on call day. From the whole hospital, the ECG is done. The second year and the third year residents, we had to interpret the ECGs, a big pile of it, and they used to be checked, cross-checked by the DMs, DM cardiology in our hospital, and that is how we learnt it, and that is the best way. You practice, 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 you make mistakes, learn, you make mistakes, learn, and never feel disheartened when you make a mistake. It is a stepping stone to success. Coming back, as you know, we are discussing about electrocardiography, and we are discussing the most important topic in ECG, which is the axis, and we have covered quite a bit of the basics of the axis, and right now we are discussing about the S wave. So what is S wave? S wave is when the electrical impulse is going away from that lead's positive pole. Now for example, you see in lead AVR, AVR is out here, but the SA is out here, and if you see SA has fired, it has fired into the atrium, the AV node has, impulses have reached the AV node, bundle of phase, and they're going, current will travel in a straight line, and lead 2 is out here at plus 60 degrees. So what is happening for lead 2? And talking about the same fund of R wave amplitude in V1. So for lead 2, current is always coming towards lead 2. It is never going away from lead 2. So what will happen? You will get a very good volume P wave, very good amplitude QRS complex, R complex, no S wave, correction. So in lead 2, you will get a good amplitude P wave, good amplitude R complex, and a good T wave. Because the amplitude of the R wave is good, the T has to be of good size. If you want to study any complex, the P wave or the QRS or the ST or the T wave, lead 2 is one of the best leads to look into and comment on, because you will get very good sized complexes, and then you will not miss anything. So for lead 2, current is always coming towards lead 2 from SA node. But what is happening for AVR? AVR is unhappy because the current is always going away from the positive pole of AVR. The SA has fired, the current has started traveling like this, away from AVR. So if you see in any normal ECG, you will see all the complexes in AVR are inverted. They should be inverted. The P will be inverted, QRS complex will be inverted, the T wave will be inverted. So in other words, if you see anything positive in AVR, even if you don't know how to interpret the ECG, something is wrong. You should be guarded, you should take an opinion from a person who can help you out in that situation. But after going through these videos, it will not happen because you will be knowing ECG so well. So for AVR, the current is always going away from AVR, positive pole. So all the complexes are perceived as negative deflection. The P is inverted, QRS is inverted, and the T wave is inverted. Then for lead 3 is out here at 120 degrees. For lead 3, you have to use little bit of imagination when you interpret the ECGs. And this is the way I have learned, and it works out well for me. It will work out good for you also. Lead 3 is at 120 degree, and the impulse has started from the SA node. For some time, for lead 3, the current is perceived as coming towards lead 3's positive pole. And then while it is going to depolarize this part of the LV, the apex or the lateral area, it will be perceived as if it is going little away from lead 3. That is lead 3's perception. So it will form a S wave. Small S wave can be there in lead 3. We'll discuss about electrical rotation of the heart in the next chapter, so it will be more clear to you. And similarly for lead 1, so it is a left oriented lead, so most of the complexes will be positive. There can be small S wave, but in lead 2 there should not be S wave, because after reaching the tip of the apex, tip of the LV, there is no place for the current to go. It is not going away from lead 2. So lead 2, there is a positive P, positive QRS complex. I'm just calling it QRS, but there is no S wave. There should not be S wave. If an S wave develops in lead 2, means at some point the current has gone away from lead 2. It is very important and very interesting when we will discuss about left anterior hemiblock, and you will see deep S waves in lead 2, lead 3 and left axis deviation, and that is how you differentiate LHB from left bundle branch block. There is a LBB in both, there is a left axis deviation in both. We'll discuss that in next chapter, otherwise we'll be all over the place. Welcome back. Welcome to Health, Music and Fitness channel, your source of reliable information, and we are discussing about the axis in this video. We have already discussed what axis is, and We have also looked into the reasons why the axis deviates or shifts, some of the important causes we discussed. And we also now know that why the R wave is small in V1, V2 because of the depolarization of the interventricular septum, which occurs from left to right. So it is perceived as positive R wave in V1, V2, negative in V5, V6. So we'll continue from here. Now again we come back to the same circle. I call it circle of life, and this is the Ithovan's triangle, which is represented on this circle. And now to how you determine the axis, how we find the axis, that we will discuss now. There are 4 or 5 ways to determine the axis, and none of them is the most accurate one. So you have to use all of them to determine the axis. The most common one is you look for the most isoelectric complex in the first 6 leads. Lead 1, lead 2, lead 3, AVR, AVL and AVF. The most isoelectric complex. What do you mean by isoelectric complex? There is an isoelectric line on the ECG paper when the recording is being traced. That is from where all the complexes, all the positive and the negative waves arise and end. That is the isoelectric line, like this one. This is the isoelectric line. So the P wave arises, originates, starts and ends at the isoelectric line. The Q, the R, the S and the T. So they all start and end at the same horizontal line. That is the isoelectric line. Ideally, all the complexes should end like this, but due to certain things, certain factors, even in a normal ECG, you might not see all the complexes starting and ending at the isoelectric line. When the heart rate is very fast, there is tachycardia. The heart doesn't get enough time for the ST to reach till the isoelectric line. So you will see a small ST slag, ST depression, which we usually interpret as rate dependent ECG changes, STT changes. And sometimes because of hypothermia or the patient has tremors, so you will not see a good isoelectric line. And mind you, every tissue in the body, it is producing electricity, and all these electrical impulses from the various muscles, the muscle fibers, they are also perceived by the ECG machine. The ECG electrodes pick up even these electrical activities from the skeletal muscles, and that is how you get the artifacts. And artifacts is nothing, it is just because of the shivering of the muscles, the skeletal muscles, and you get some indurations, a wavy isoelectric line, or the QRS complex is a little fuzzy or dizzy. So that is because of the tremor or shivering, or the less jelly is applied. If less of jelly is applied to place the ECG electrode, you might get an artifact. Or if there is some other electrical appliance connected to the patient, some ventilatory current or some electric bed is there and some current, or there is no proper earthing in the ICU, you will get artifacts on the ECG. So this was about artifacts. Welcome back. Now you have to look at the most isoelectric complex from lead 1 to AVF. First 6 leads. 1, 2, 3, AVR, AVL, AVF. What I mean by isoelectric is where R roughly equals to S. The height of the R wave should approximately be as the depth of the S wave. Sometimes you will not find an appropriate or the isoelectric complex, but you might see something like R wave is 5 small squares, S wave is 4 small squares. So you can say R wave and S wave, that lead is isoelectric.
Now look at this ECG. Now I have given you this ECG, and first of all you look at the calibration. So this is the calibration. It is a perfect calibration, 10 small squares in height, and the plateau is horizontal. So this is a perfect calibration, and you can comment on this ECG. And out here we are just talking about the isoelectric complex and the isoelectric line, and this is the isoelectric line where P is starting, ending, QRS is starting, ending, and T is starting and ending. This is the isoelectric line, and you see in the first 6 leads, lead 1, lead 2, lead 3, AVR, AVL and AVF. In this sequence you have to always talk about these first 6 leads. Here are, let us assume, if you count, it is 4 small squares and S is 3 small squares. So 4 minus 3, it is plus 1. So lead 2 is positive, and you can say it is isoelectric. Lead 3, R is maybe 1 or 1.5 small squares, and S is deep. S is 5, 6, 7, 8, 9 small squares deep. So QRS is negative in this, and 9 minus 1, 8. So this is not isoelectric. Then you look in any other lead, and mind you, Q wave you cannot take for finding the axis, and like in this is lead, this is a Q wave, there is no positive upstroke slur, so you can say this is a Q wave, and you cannot this is a Q wave, this is a Q wave because of old MI, and you cannot say this is S, and you cannot say this is negative. For finding the axis, how much is R and how much is S, you have to look only for R and S. This is the take home message for this ECG interpretation. This ECG has lot of findings, and it will be confusing if we discuss all those out here. So in the first 6 leads, lead 2 is the most isoelectric complex. Now the axis will lie perpendicular to it. Okay, the most isoelectric complex, and the axis lies always perpendicular to it. So lead 2 is at plus 60 degree, and perpendicular to plus 60 degree, what is the lead? How many degrees is it? Minus 30. Okay, so minus 30, that is where AVL is placed. So that is the axis. This ECG also shows a left anterior hemiblock and old anterior wall MI with lateral wall ischemia and few other things. We will discuss those in the later ECGs when we come to those topics. Right now lead 2 is the most isoelectric complex, perpendicular to that is minus 30 degree AVL. So AVL is at minus 30 degrees. So axis is at minus 30 degrees. Now you might say, why can't I draw a 90 degree line towards the right axis deviation quadrant? So that circle, you remember, out here. So lead 2 is out here, and we are saying it is minus 30 degrees. Why can't it be plus 150 degree, plus 150 degree? That is because there is a S wave in lead 3 and 2 and AVF. So when you look at this lead, this is negative. QRS of AVF is negative. So we are plotting at the minus 90 endpoint. So the axis is between 0 degree and minus 90. Then you adopt this method, isoelectric, perpendicular to that, minus 30 degrees. Then the third method you can use is, you can draw a rectangle. So let us say now in this lead 1 is plus lead 1. So you look at lead 1, there is no S wave. Okay, so lead 1 is predominantly positive. So this is 5, 6, 7, 8, plus 8. Lead 1 is plus 8 positive, and lead AVF. Then you look in AVF. AVF is, let us say, 5, 6, 7 minus 2, 5. So, lead AVF is negative minus 5. So, you have to draw 7 dots on the isoelectric line, line which is going to the center of the circle from 0 to 180 degree. So, 7 points like this and 5 points like this, and you draw a rectangle. You join like this and draw a rectangle, and the diagonal of that will be the axis. I will show you in some other interesting ECG. Right now, for this ECG, this is the isoelectric complex lead 2, and perpendicular to that is the axis. Most of the times you will be successfully able to determine the axis by using these two methods. In this ECG, if you see the first 6 leads, lead 1, 2, 3, AVR, AVL, AVF, always in this sequence. Then you see the tallest star, I call it the James law. The tallest star is the axis. So, when lead 1 is positive, AVF is positive, you can just look for the tallest star wave, and that is the axis, because the electrical vector is directed towards that lead only. Okay. So, in this ECG you see lead 1 is the isoelectric complex where R roughly equals to S. Then see lead 2, very tall, nice R, very good P wave, and there is no P wave out here. So, you can say this is a ectopic beat, okay, maybe from the AV node. Then out here R is tall, but not so tall as in lead 2, and always in this ECG machine it gives a long lead 2 to interpret the arrhythmias. So, in this ECG there are few arrhythmias, ectopics, but we are not discussing that, and this is not isoelectric. So, in AVR everything is inverted, P is inverted, QRS is inverted, T is inverted. So, means the impulse has arisen from the SA node and it is going further directly towards lead 2, and lead 2 is very happy because all the electrical impulses are coming toward lead 2. So, it is showing a very nice P wave, very nice tall R wave, and very nice T wave. In this ECG T is not that good, maybe this patient has a subtle ischemia which we can only make out on coronary angiogram. And mind you, ECG can be normal, echo can be normal, treadmill test can be negative for inducible ischemia, and patients all 3 branches coronaries might be blocked 99%. Okay. Coronary angiogram is the only definitive diagnostic tool for diagnosing the patient as having a block in the coronaries. So, tallest star is the axis. So, in this ECG you can confidently say that your axis is at plus 60 degree, lead 1 is positive, AVF is positive. So, the tallest star is the axis, James law. Okay. Then you try, let us try the other methods, isoelectric and perpendicular to that is the axis. So, lead 1 is the most isoelectric complex sort of, and perpendicular to that lead 1 will be plus 90 degree, but mind you the R wave is slightly taller than the S wave. So, it is not a perfect isoelectric, it is not making a perfect 90 degree, it is pulling the axis slightly away from plus 90 degree. If R is tall, but we are taking lead 1 as isoelectric, and but R is taller than the S wave in lead 1. So, it is not a perfect 90 degree because lead 1 is slightly positive. So, it is holding like it is deviating the axis towards lead 2 point. So, again we are going to plus 60 degree. So, this is how you interpret, and if you draw a rectangle and you see the diagonal, it will come to plus 60 degree. Till now we we have discussed the different ways of finding the axis. First is look in lead 1, look in AVF, and if lead 1 is positive, AVF is positive, we plot at 0 degree plus 90 degree and the axis is between 0 and plus 90. Then you look at the most isoelectric complex and perpendicular to that is the axis. Then the third method I said was James law, tallest R is the axis if lead 1 is positive and AVF is positive. Then the fourth method is you draw the rectangle. Let us say if lead 1 is 10 positive, AVF is 10 positive, and the rectangle and the diagonal, that will be the axis. Most of the axis you can find out by these 3 or 4 methods. Then sometimes you want to say whether it is 29 degrees or 28 degrees axis. For that accurate determination of the axis, you have to use tan theta method, in which we calculate the tan inverse. At this point, I am very thankful to Dr. Saurav, my colleague, who taught me this method. Like I always say, when the student is ready, the teacher will appear. When the student is ready, your guru will appear. For this tan theta method, Dr. Saurav is my guru, and always respect your teacher, no matter whether he is elder to you or junior to you. And even after learning, like the Bible says, the student can never be greater than the teacher. Always stay humble and you will learn more. You will get more gurus around you who will teach you. And also, it's not like something bad, the guru is inside us. If you are ready, if you are humble, your brain, your mind will open up and you will imbibe so much of wisdom from everywhere. From everywhere teachers will appear. This I firmly believe. So, coming back to this tan theta method, in this we have again drawn that Isoelectric triangle, the circle, lead 1 at 0 degree, lead AVF at plus 90 degree, lead AVL at minus 30 degree, lead 2 at plus 60 degree, lead 3 at 120 degree. So, we will be talking about this quadrant in this example. Now, let us say lead 1 is plus 4 positive, AVF is plus 2 positive. So, you draw a rectangle like this, and mind you, a rectangle has 4 90 degrees. So, this is 90 degree, this is 90 degree, this is 90 degree, this is 90 degree, because a rectangle has 4 angles and all are placed at 90 degree. Now, we have to find this angle, and to find this we have to apply the tan theta method. So, if you draw a diagonal, we are basically splitting the rectangle into two triangles. In that case, we are looking at this triangle. Now, you forget about this. So, this 2 of AVF plus 2 of AVF becomes the height of this triangle, and lead 1 was always the base from the beginning, and base is 4. We have calculated hypothetical calculation. So, lead 1 was plus 4 positive, AVF was plus 2 positive. So, we have divided the rectangle into 2 triangles, and this was 90 degree. So, this is also 90 degree, and this is the theta, and we have to find the tan inverse. So, for tan theta, the formula is height divided by base. So, in this case, this plus 2 becomes the height of this triangle, and the base was 4. So, 2 divided by 4 is half. So, tan theta equals to 1 by 2. or theta equals to tan inverse 1 by 2, and this will come to 26 point some degrees we had calculated when we were discussing it. So, it comes to roughly 27 degrees. So, this is the most accurate method to determine the axis of the QRS, and again I am very grateful to Dr. Saurav for teaching me this. So, in nutshell, these are the different ways of determining the axis. Still you will confront some ECGs where you cannot comment on the axis. There will be isoelectric lead 1, isoelectric lead AVF. In that case you say axis is indeterminate. So, you do not comment on the axis, you cannot comment on the axis. So, you say axis is indeterminate. Now your aim should be, whenever you are confronted with an ECG, rate, rhythm, axis, and the moment you are looking at the first 6 leads, lead 1, lead 2, lead 3, AVR, AVL, AVF, if lead 1 is positive, even if it has a S wave, you see R is more or S is deeper. If R is more, axis is around 0 degree, that is for sure. Now, we have to determine the degree, it could be minus 10, plus 10, plus 30, minus 30, like that. So, if lead 1 is positive, axis is around hovering around 0 degree, then you look at AVF, look at lead 2. So, whatever is isoelectric, perpendicular to that is the axis.